各位早晨。
Members, good morning. It's a few minutes past the appointed time and we have a quorum. So I call to order the 6th meeting of the Bills Committee on Marriage Amendment Bill 2014. So let's invite the administration in, and we're delighted to have invited medical professionals to have a discussion with us today. So I'll first invite them in, and then we'll start the discussion. This meeting is scheduled to finish at 10:30, and there'll be another meeting in this room, so we're not going to extend the meeting, and we need to keep watch of the time, and our medical professionals will, in a moment, be invited to address the concerns of members. And then members will be able to ask questions and give their views on this issue to share with the experts. And if there is still time left, we will continue our discussion with the administration. So that will be for today's arrangement. So thank you. May I welcome the doctors who will be discussing some issues on the Marriage Amendment Bill with us. And we have invited from Kwai Chung Hospital, Dr. Ho Pui Tat, Associate Consultant. And from Castle Peak Hospital, Dr. Greg Mack, Associate Consultant. And from Academy of Family Therapy, we have the Clinical Co-Director, Dr. Manon, and a specialist in psychiatry, Dr. Hong Kwai Wah. And also from the administration, we have Ms. Maggie Wong, Deputy Secretary for Security, Mr. Billy Wu, Principal Assistant Secretary for Security, and Mr. David Chiu, Assistant Director from the Immigration Department, and Mr. Alan Chong, Senior Government Counsel from the Department of Justice. So I'll first invite our 4 medical professionals to briefly walk us through the issues, and let's say we'll spend 5 minutes on it, and then I believe members are very keen to ask more questions on the issues of their concern, and they would like to exchange their views with us, with you. So may I first invite Dr. Ho Pui Tat. Thank you, Chairman. I'd like to thank the Bills Committee for inviting psychiatrists to attend this meeting to explain to members the preliminary assessment and treatment before the SRS, the sexual reassignment surgery, is taken. We would like to explain to members what we can do to help these patients and what services are available. And to facilitate my presentation, I will be using some medical terms, and I'd like to talk about these terms first. Gender covers a wide dimension, and sex and gender are 2 different terms in medical terminology. In terms of sex, we're talking about the sex organs, chromosomes, and hormones. As for gender, we're talking about psychological features or social features in terms of their social roles and their personal emotions. So sex is something more physical, whereas gender involves more, covers a social or psychological scope. Of course, for gender, in fact, apart from male and female, there could be other types, but I will just talk about male and female. For the male gender, it means that he plays the social role as a man, and in terms of men and women, and I mean, it's a kind of orientation, and for these patients requesting for sexual reassignment surgery, they have the symptom called gender dysphoria, and there is an issue with the gender recognition. Although biologically they have the sexual organ of one sex, and they find difficult to recognize themselves with this sex. So together with other symptoms, there are other symptoms. For example, they would like to eliminate their own sexual features and to have the sexual features of the other sex and be recognized as the other sex or gender. And this is from the ICD, a kind of disorder. And according to the ICD, they also have the gender, they also classified it as gender dysphoria. And in terms of severity, the features or the symptoms might range from moderate to serious. And when it is serious disorder, we call it the transsexualism. So this is towards the more serious end. And for these patients, they have strong urge to change into another sex through treatment, including the sexual reassignment surgery, SRS. And for gender identity disorder or gender dysphoria, we're talking about only 1 out of several 10,000 patients. So it's not common. And every when we're talking about from male to female, it's 1 out of 11,000 to 30,000 population, and for female to male, that's roughly 20,000 to 100,000. So out of 4 patients, 3 would like to have their sex change from male to female, and 1 from female to male. And we will also say that this is just the tip of an iceberg. It might be just the tip of a pyramid. There may be other people who are less well-defined in terms of this disorder. And we don't have any conclusive evidence on the cause. It may be due to inherent as well as social or environmental factors. For this symptom, if no sex reassignment surgery is carried out, it is not possible to cure the disorder through merely medication or psychological therapy. So I talked about gender dysphoria spanning across a spectrum from moderate to serious, and for serious patients with serious conditions, they might have to seek help from professionals, including psychiatrists. And Hong Kong does have quite a long history of several decades in treating these patients, and we have the relevant services for them. As for the position of HA on patients with gender identity disorder or gender dysphoria, the HA place emphasis on the best interest of patients. They provide psychological and physical therapy for gender dysphoria patients. and the medical staff will be happy to give medical and scientific evidence on relevant treatment. As for gender recognition, it's beyond the medical professional area, and it's essential that the community discuss the issue together. So on the arrangement of treatments, any registered medical practitioner can refer such patients to the Department of Psychiatry of HA, and there'll be an interdepartmental medical team, including psychiatrists, clinical psychologists, and also endocrinologists, surgeons, gynecologists, social workers, etc. Psychiatrists are responsible for coordinating the necessary treatment for these patients at different stages. And in 2013-14, there were 121 patients receiving treatment in our Department of Psychiatry, and 12 patients have received SRS. As for assessment and treatment, we'll meet with the patient and the family members or members or persons important to their lives in the clinic, and we will assess the patients to give information and support to these patients, and we'll also draw reference from international guidelines such as WPATH Society to formulate treatment plans best suited to the patient's needs, and to discuss their treatments and options. And we don't have any preconceived position whether the patients must undergo the surgery or not. The patient has full autonomy in deciding their treatment options, and we will not impose any kind of treatment which they do not want. As for treatment, there are various kinds, including psychological treatment such as counseling. Our goal is to help them enhance their gender recognition and to help them become more resilient, and if they find themselves being able to cope with the situation, we will then turn to real-life experience. And with the support and counseling of a psychiatrist, the patient will be living in the gender that the patient wishes, and this will be for the period before transitioning to the new gender.
Is followed by hormone treatment. After we've given hormone treatment, there will be physiological changes in the patient, and that really will help the patient psychologically. We will closely monitor the how the hormones might affect the arteries, because the the medication may cause cancer. After the patient has gone through a successful real-life experience, we'll consider when the patient will be when it will be appropriate for the patient to undergo SRS. To undergo SRS, the patient will need to have the recommendation of two doctors, a psychiatrist and a clinical psychiatrist. The SRS would involve the process of removal and reconstruction. As I said, the gender identity disorder is actually a spectrum, and not all patients will need to undergo all the treatments. Some patients may only choose to receive part of the treatment. The best treatment protocol is for us to have a detailed discussion with the patients regarding the risk of the different treatment protocols and its effectiveness. So it's all based on the best interest of the patients. Thank you, Chairman. Thank you, Dr. Ho. Next, Mr. Mann. Dr. Mann. Thank you, Chairman. From 2009, I have been handling the treatment of transsexuals and also providing counseling for such patients. Dr. Ho already explained to members how psychiatrists look at the question of transsexuals, and also for transsexual patients and those who want to undergo an SRS, what would be our usual practice. Over the past 5 years, I have been in contact with about 91 patients. In our clinic, we've conducted a small-scale survey, of which 55 people were born male and 36 female. Amongst them, more than half of the patients eventually would need or have this strong desire to undergo the SRS treatment. Among the 50%, 90% of those patients are those who want to change from male to female, and 50% would be female who want to to change to become male. Like Dr. Ho said just now, other than providing the diagnosis and find out the crux of the problem, basically we would provide counseling and help enhance or clarify the patient's wishes. I'd like to emphasize that the treatment is based on the choice of the patients. We do not insist that they must satisfy certain requirements or they must undergo SRS before we would treat such patients. The purpose of our treatment is to facilitate the patients and to help them achieve the best and the most comfortable outcome. So there is no question of our compelling the patients or imposing any unnecessary treatment on these patients. Myself and Dr. Ho practice in public hospitals, and I don't think I will repeat the details which Dr. Ho has already covered. And perhaps I will, save time for my other colleagues. Dr. Ng, I'm Mun Leung. The honorary professor in the Department of Social Work and and the Academy of Family Therapy, which I was previously a professor of psychiatry at the Hong Kong University. In 1985, I built up the first sex clinic in the Queen Mary Hospital to treat patients with sexual dysfunctions and sexual disorientation, including the sexual identity group, which look after patients with gender identity disorder. We assess whether or not the patients can receive SRS. From 1985 to 2007, the year in which I retired, I've actually worked for 22 years. I've led the working group and assessed more than 100 transsexuals, and of which about 50-odd people had undergone SRS after the surgery. Other than the surgical issues involved, most of them were able to live a satisfactory life, and there had never been a single medical incident. No patient had ever regretted or for having taken the SRS, and no patients had sued me for performing such operations on them, or that they were not satisfied with the operation. Since I retired, I have not personally treated such patients, but I've always all along been participating in different conferences on sexual disorder, and I participated in catching up with the latest trend in the provision of service for transsexuals. I'm also a member of the of an international committee, and last year, together with a doctor in Taiwan, I was asked to translate the health health protocol for the gender non-conforming people, and the WPATH is the authority on the care of transsexuals. Transsexuals are now legally allowed to marry. My personal view is that I'm in favor of that because it can help enhance their quality of life and also safeguard their rights so that they can lead a life like those of other normal people. But over the last few decades, the experts in SRS in different jurisdictions, including myself, the experience shows that sexual identity recognition is has something to do with the psychological state of the person. It has nothing to do with the sex organs. Requiring them to remove the original sex organs and replace it with a fake sex organs before they are allowed to marry does not make sense and in medical sense. It is only a legal obstacle to make things difficult for them. Of course, the surgery is not a torture. Any operation which the doctor performs on the patient cannot be called a torture if the patient consents to the operation. But this is an unreasonable, requirement which is discriminatory. Many transsexuals hate their sex organs. They would like to have them removed. But on the other hand, there are many transsexuals who do not hate their sex organs. They would prefer to bear with it rather than having to undergo this, major operations. For some transsexuals, due to the physiological state, are not suitable to undergo such major operations. And this would be even more unfair to these patients because they'll never be recognized by the law. Similarly, the SRS is a meaningless barrier. The operation and the medicine and the transsexuals, of course, if they volunteer to undergo the operation, that would be fine. But I don't think it should be a precondition before they can be given a new sexual identity. Under what conditions would reassigned sex identity be accepted? The practice varies in different jurisdictions depending on how civilized or open the society is. In the most ideal situation, we can learn from the practice of Argentina. From 2012, transsexuals do not require consent from a judge or a doctor to freely change the legal the sex status in law, and then they can marry according to the new or sex gender identity. In Germany, in 2014, the patient only require support from 2 medical experts, and the 2 persons have cohabitated for 2 or 3 years, and they have the desire to change to have the sex reassigned, then they will be allowed to do so, and they can get married, and they don't need to go through an operation. In Germany, there is no minimum age requirement for sexual reassignment. In different countries, they have different ways of coping with the problem. For countries which accept gay marriage, this is totally unnecessary. For transsexuals, even if they belong to the same gender, they can still marry. For other countries, they would allow the transsexuals a 3rd, 5th, or even 6th gender, and this can help bypass the issue of same-sex marriage. For some people, they would only marry someone of the opposite sex. If there are only 2 sexes, then it would mean that only a man can only marry a female, and vice versa. If you allow for 3, 4, 7, 5, 8, gender categories, then a person can marry someone of a different sex gender, and that way we can avoid the controversy over same-sex marriage. In some countries, they would only require the patients to take certain medication, and where there are exceptional grounds, like for some patients, it's not suitable for them to take medication, it's not suitable for them to undergo the surgery, then they can be exempted from such requirements. Of course, there are many other countries like Japan, Denmark, and Finland, and Czechoslovakia, where they only allow two persons the transaction to marry only after they've undergone the SRS. Although the law varies from jurisdiction to jurisdiction, and some are more advanced than the others, but what is obvious is that many countries in the world are now moving towards the same direction. That is, we should try to be more open and more tolerant, and then we should try our best to minimize the unnecessary obstacles and respect each person's right to freely choose their lifestyle. As to when this ideal can be achieved and when this could be achieved in Hong Kong, I do not have any false hopes. I just want members to bear in mind that Hong Kong hopefully will not be too much behind other jurisdictions. Next, Dr. Hong.
Thank you, Chairman. Thank you, members. So something about myself first. In 1988, I left the government and went into private practice. For over the past 3 decades, I have strived to help and counsel sexual minorities such as sex addicts, homosexuals, transsexuals, adults and children with gender identity disorder, and transsexuals, and also families of transsexuals and sex minorities. In 2004, I established an organization. In 2012, I also established an alliance, and recently I set up a mutual help organization for parents of transsexuals and transgendered persons. And I heard the discussion on the 20th of May in LegCo, and questions put to Dr. Albert Yuen, and I would like to share my experience as a private psychiatrist, because as a private medical practitioner, sometimes I encounter cases different from cases in public hospitals. So I have 3 points to make. First of all, as a psychiatrist, how do I help patients with gender identity disorder? Then that's the old classification, and the old term for this condition is GD, gender dysphoria, as said by Dr. Ho just now. And for GD, there are different age groups. There are GD for children, teenagers, and adults. And transgender recognition or conduct can surface as early as 2 to 4 years old. And the basic principle for treating GD is to eliminate or at least reduce the inconsistencies between the psychological gender and the biological sex, so as to reduce the anxieties and the stress. So there are 3 ways. The first way is to change the psychological gender to align it with the biological sex. And the second way is to accept the inconsistencies throughout their lives and to live with the difference. And the third way is to change the biological sex to align it with the psychological gender. So for the first point about changing the psychological gender, it seems to be easy, but the success rate for adults with GD is very, very low. About the 10 odd cases I came across in the past, this method could not eliminate their the inconsistencies in gender recognition of the patients. As for GD for children, the success rate is higher. There is no need to interview the children during the treatment process. What we do is to help parents change the parenting method, and the child will change correspondingly. Last year, I helped the parents of a 4-year-old children with GD to successfully help the children change their psychological gender within 8 months. So for adults with GD, this method is not very successful, but it's more successful in the case of children with GD. The second way is to help the patients accept and to live with the inconsistencies in the gender recognition, psychologically and biologically. I don't know whether in public hospitals the patients' conditions are more serious. In my case, at least, I had 2 successful cases using this method. I help the patients live in their biological sex, although every now and then they may cross-dress, but gradually they become happier, because apart from the problems with gender recognition, there are ways to help them live in a new gender identity. The third way is to change their biological sex by way of, say, cross-dressing, application of sex hormones, or sex reassignment surgery. Some patients require full SRS, some don't, and I also like to share with you that a person's gender identity should not be determined only by his or her psychological orientation, and disregard whether the external biological features align with their gender identity or not. Because if you have another gender identity, you can enter the bathroom or changing room of another sex, just like the case of Colleen Francis in the U.S. Colleen Francis is a transsexual from male to female, but the male penis was not completely removed. And in a secondary school's female changing room, he exposed his penis, and the female students felt so shocked and embarrassed. But as he was protected by the gender recognition ordinance of the state, the students and parents could not object. And let's imagine if a man exposes himself in a public place, females may feel shocked and they can call the police. However, in this case, in a bathroom, females are very vulnerable. They may be naked or wearing very little, and they may feel even more shocked when seeing a man's penis. However, because the government is protecting transsexuals' rights, their rights are being deprived of. So I understand that some transsexuals do not require full SRS, but on the other hand, without this surgery as a threshold or criterion, there may be cases like what I've mentioned. Of course, the sexual minorities should be protected, but what about girls of 8 or 10 years old? Aren't they also a vulnerable group? I think we need to strike a balance. So I think that a full SRS should be necessary to align the person's external features with their psychological condition to prevent giving a shock to others. So much from me. Thank you, 4 doctors, for sharing with us their knowledge in great detail. And I believe members are also keen to exchange their views with the doctors as well. We have Dr. Priscilla Leung, Ma Fong Kwok, Tommy Zhang, and who else? We also have, all right, please put up your hands. Mr. Yu Siwing, Emily Lau, Paul Chair, Sid Ho, members may like to have a second round, so for the time being, 4 minutes first. Dr. Priscilla Leung. Thank you, Chairman. I thank the doctors for coming here and explaining their views with us. Now, last time we learned that for transsexuals requiring sex reassignment surgery, they termed transsexualism or gender dysphoria. So it's kind of a psychiatric illness. It's a kind of mental illness. And last time, and also on this occasion, you mentioned that these patients, on their own initiative, request for surgery to be carried out, and they feel happier afterwards. And I have come across a case. There was a person undergoing a sex reassignment surgery, and afterwards the patient made a complaint. For example, there was a complaint, as Dr. Hong mentioned just now. The person went into some place and gave a performance, and then he was being complained of, and then he complained about being discriminated against on the grounds of his disability. So it means after the surgery he becomes disabled person. So unlike some other cases of people with disabilities, this person asked for the surgery himself, and yet afterwards, because of different opinions, this person then complained others of discriminating against him on the grounds of disability. So I'd like to know your view on this. Will they be protected by the discrimination against disability ordinance afterwards? And also I'd like to ask Dr. Hong, before a full SRS, what if a patient wants to revert back to his own gender? And we have also heard other cases overseas of this kind, regretting about the surgery. So, Dr. Hong, I'd like to ask you whether there are any cases on patients wanting to revert to the original gender, and also on the disability case. And I feel really shocked because I never view them as people with disabilities. 4 minutes for each member. You may want to give your views. If you want to ask questions, please give doctors time to answer. All right, Chairman, please save my time. I just want to remind members, I'll give you back some time. You have to allow other members ample time to make their views known and also to ask questions. Dr. Hong. I want to clarify with Dr. Priscilla Leung. I never talked anything about reverting to the original sex. For the second method, it's not about reverting to the original gender, but to help the patient live with the inconsistencies thereafter. Just like a woman unhappily married to a husband, she's not willing to get a divorce, and we help this woman live with the unhappy marriage. So this is not about reverting to the original gender. And on your question, there are just few cases of this kind. There was a case in the Philippines the surgery was carried out from male to female, and because of religious grounds, the female transsexual then wanted to turn back to become male. But such cases are rare. Whereas for other situations, I have 2 cases for real in terms of real life experience. The patient then found that whilst living as a female, his position professionally was compromised. Whereas I have little time left, doctor. I have this case requesting for assistance. What is your view on the disability issue? In fact, after the surgery, you can say that this person has become happier, but there are still other issues, in particular these psychological aspects. There may still be struggles to recognize his own gender, and these cannot be eliminated just by surgery. And their families and friends may not accept his acquired gender after surgery. Sorry, I have to ask your view on disability. I still view this patient as a disabled person. So that's your view. But he takes the initiative to carry out the surgery. That's a kind of treatment for his disability. Mr. Ma Fung Kwok.
Thank you. It's a big challenge if we can only have 4 minutes. Now, I'd like to direct a question to Dr. Hong. There are 2 types of persons. One would be those who would like to go for a full SRS in order to acquire a new sexual identity. The other group doesn't have such a demand. They would only go for part of the treatment. So without considering that, so if a person doesn't have the subjective wish to undergo the operation, but they would like to, have the feeling of belonging to the opposite gender identity, would you regard such persons as having a gender identity disorder? How would you regard such people? Would you regard them as normal men or women, or would you consider them as someone who has people who have problems with their gender identity? For someone who doesn't want to go through the operation and those who want to go through the operation, would the letter would their gender identity be less strong, and that they're more likely to change? To answer your first question, if you look at these 5 diagnostic criteria, there are 6 criteria. So long as the patient satisfies 2 of such criteria, he would already be classified as suffering from gender dysphoria, one of which is removing his or her sexual organs. In diagnosing gender dysphoria, this criteria is not necessary. If the person doesn't want to go through the operation, or if you only go for part of the operation, he can still satisfy the criteria for gender dysphoria, because they have satisfied 2 or more than 2 other criteria for gender dysphoria. So we simply follow the code. To answer your second question, that is, for patients who demand for a full SRS, as compared to those who do not ask for a full SRS, is there a difference between them? Actually, the behavior of transsexuals, there are actually 8 categories. Some are more extreme than others. The most basic would be someone who has there's an inconsistency between the physiological identity and sex identity and the psychological identity. There's also variation between those who would go for all the way out for SRS and others who would only want hormonal treatment. For those who insist on going through the entire SRS, the case would be more serious. But so far, there have not been any studies to differentiate them. We cannot say for the time being that those who do not ask for SRS must belong to the milder category, and those who ask for operations would belong to the more serious cases. Follow-up question. Some people say that for each of these transsexuals, they very much would like to go to the operation, except that the operation is too painful. In your actual clinical, according to your clinical experience, would that be an accurate statement? I think the crucial point is that the definition of transsexuals is that the person would very much like to live as someone of the opposite gender identity. Some people would like to go for hormonal treatment. Some people would want the entire physiological traits to be changed. So my statement that I quoted just now is not accurate. Yes, that's correct. Starry Lee. First of all, I'd like to thank all the experts for coming to share with us their views. I'd just like to confirm one point. My question is similar to Mr. Ma. And if the experts don't agree, please enlighten me. Having heard Mr. Yuen and the other doctors, I think the conclusion is that the full SRS is not a torture, and that is a matter of voluntary choice for the patients. Secondly, I'd like to ask a question for Dr. Man Lun. In your sharing earlier, you said that you participated in, you've joined many international organizations. You say that many countries are now becoming more ready to accept the transsexuals. But I've also seen in countries where there is a lot of social division as a result of their allowing gay marriage, and Taiwan would be a typical example. Although I fully understand that the people with gender identity anxiety, and I sympathize with the anxiety that we go through, and we have to respect their choice. While we're thinking of protecting their rights, we have to also consider the issue of reverse discrimination, and that is actually the justification for those people who oppose gay marriage. And so, as Dr. Hong had just shared with us a case in the States, while we need to protect people with sexual disorders, but at the same time, in doing so, we will not be able to protect the rights of women and children, and while we protect the sexual minorities, how do we at the same time protect those people who truly believe in monogamy and marriage between men and women? So, Dr. Ng, you participated in many international organizations. Have you ever explored this issue? Well, to whom would you like the question to be answered? Dr. Ng. I'd like to thank the two members for the questions. Before the transsexual had undergone sexual reassignment, whether or not the behavior would offend the lifestyle of other people who are more conventional. Even though if these patients are disabled, even if they are sick, even if they are transsexuals, before and after the operation, it's not true to say that their rights will override those of others. If they, engage in activities which would offend society. Dr. Hong cited the case of someone who has not gone through a complete SRS and he still has the male sex organ on his body, he goes to a female toilet and exposes sex organ to other women, he would be actually offending other people. I've worked with transsexuals for many years. Very often before the operation, we would already encourage them to go to the female toilets because they would need to, try out, the life of someone who has gone through a sex, reassignment. They would not go to a female toilet and expose his male sex organ. If this person goes to a female toilet, whether or not it has a male sex organ, even if a woman going into a female toilet and exposes sex organs obscenely, he would be breaking the law. It has nothing to do with whether or not a person has gone through the SRS or not, whether or not it goes to a female toilet or not. So long as he engaged in an obscene behavior, he would need to be punished. We would teach these patients to go to the female toilet before the SRS. We always tell them to respect all the etiquette and that they should not expose the sex organs or engage in any activity or behavior which will cause fear or panic among those others in the female toilet. The most important issue here is not to cause any panic. I think then it would be all right. For most of the patients that we treat, or most of the transsexuals, before they go through the SRS, as far as my patients are concerned, they have never gone to a female toilet to expose their organs. I mean, it would depend on how the doctor, counsels the patient. There's no question of reverse discrimination here. There's no logic to this argument. If he really has offended you, you can still, punish him according to the law. Mr. Tommy Cheung, followed by Mr. Chen Kim Pong. Thank you, Chairman. I'd like to thank all the experts for sharing with us their expert views this morning. Most of us are laymen on the subject. I'd like to follow up on a question raised earlier by my colleagues. Is it the case that when psychiatrists have diagnosed a person to be suffering from GD, would you regard them as disabled persons? Although as a layman will not be able to identify the symptoms, would you already regard these people with GD as disabled persons? Dr. Never mind whether or not they go through the SRS. When he comes into your clinic, you find that he suffers from gender dysphoria. After you've given diagnosis, would you regard them as disabled person, even though ordinary people will not be able to differentiate them from other people? The definition of disability, not to talk about mental patients, even for other diseases or other specialty, we would look at how the disease will affect the person's ability to work. Let's say someone suffering from hypertension, he may still be able to go to work and have a very fulfilling life. I'm not talking about whether it's fulfilling or not. I'm asking about the definition of disability. After you've made the diagnosis that this person is suffering from gender dysphoria, medically speaking, would this patient be regarded as a disabled person? Because I've heard my colleagues asking the question that whether or not the patient goes through the SRS, and after you've diagnosed the patient as having the syndrome, how do you as doctors define whether or not this person is disabled or not? I understand that you're asking whether or not the diagnosis is equal to the disability. I think it would depend on what are the symptoms of disability on this you've observed in this patient. For example, you may encounter difficulties in the course of or in the daily life and so on. So I think the diagnosis would not. We will have to look at how the syndrome affects the way he go about his daily life and so on before we consider whether he's a disabled person. Like I said, many people may have different types of diseases. They may have no signs of disability. They may live like all normal people. At what age would a person be diagnosed to have GD? Would it, only appear after they reach a very mature age and after they are married, that they suddenly discover that they have this, gender dysphoria? Well, there is a spectrum that we're talking about. For the most serious transsexuals, they would have already found that they have this problem at a very early stage, even when they were attending kindergarten. I understand that. But you talk about the spectrum, but there is no definition in terms of age. Would you have patients who suddenly discover that they have GD at the age of 60? No. According to the American Society of Psychiatry and also I think we have children with GD and adults with GD according to definitions by international medical organizations. Dr. Ho, you say that there will be one such patient out of 20 to 100,000 people. So this is a very... take Hong Kong as an example. If it is one out of 20,000, then we're talking about more than 100,000 transsexuals. In different countries and jurisdictions, will the figure vary? Dr. Ho, as I said, such statistics are collected by sex clinics, and then the patients come to our clinics, and then we will compile the statistics. So whether or not the medical system can easily access such data, I mean, for those who don't come into our medical system, and we really don't know how many other such patients are there outside our system. Chairman, a simple follow-up. If I may ask whether the government can give us such figures. That is, in different jurisdictions, do we have such figures available? Does the administration have such figures? We will need to consult with the relevant policy bureau to see whether such figures are available. Mr. Chen Kim-po.
Thank you, doctors, for enhancing our knowledge. Now, Dr. Ng Menon, he is on the more lenient side, and still, for Dr. Ng, he doesn't think that the SRS is a torture. Of course, as a medical professional with experience, he doesn't think that this is, the surgery is torture, so it's really helpful for us to learn more about this. For sex reassignment surgery, it also has to do with the culture of that country, and the reverse discrimination. I won't say that it is never possible at all, because their social conduct would affect others in society. I do have questions as to whether this their so-called complying with a certain social code of conduct can face up to legal challenge. Even if these patients are not intentional in exposing themselves in female washrooms, the threshold is nevertheless too low, and it is also a question whether the community would accept it or not. So, Dr. Ng, from your perspective, you talked about patients in cases you came across, and perhaps for these patients, psychologically, they will not be intentionally engaging in such behavior. But from women's perspective, they don't like to see anyone with male sex organs in their bathroom. So I'd like to hear more about your view and the experience overseas. Dr. Ng. A normal person who would have regard for others will not just enter a ladies' washroom with the appearance of a man, because he will cause alarm among females, and that's how we educate them. They will not enter the ladies' washroom with the appearance of a man. So as long as he causes alarm, let's say even in a men's washroom, if somebody next to me keeps peeping at me, he might cause alarm. He might cause me to be alarmed. And if he peeps, if he touches you, then that's against the law. It's indecent assault. The law can be enforced, and that's the end of the matter. So this person can be punished under the law, and that's why we teach transsexuals that they should comply with the law, and as long as they do that, they would be fine. And frankly, I have came across so many cases of transsexuals throughout my years of practice, and they've never engaged in such a thing. Yes, but my point is, Dr. Ng, if the threshold is so low, then there could be people not the same as patients that you treated. Well, just sue them. Yes, you may sue them, but not all of them. Well, I really doubt if this is the correct way to do it. Well, many persons who have undergone sex change surgery or who are cross-dressers, well, as long as others are not aware of what they're doing, then that's fine. And in fact, across the world, there are theories that we should degenderize. That is, we should do away with the concept of gender. Gender is now a superfluous concept when we talk about equal rights for males and females, and you're still just focusing on the issue of gender, then this is already not equal. So we should do away with the concept of female or male gender. And this is just a perspective of some. Of course, there are other views, there are opposing views, and that's right. If the community have concerns, and if there are issues with whether the law can be enforced, then we must convince those who are not yet convinced. Mr. Yu Siwing. Thank you, Chairman. Now, Dr. Hong said that for adults with GD, the success rate is low in changing their psychological gender recognition, but the success rate is higher for children with GD. So, along the same lines, my question is, what if the parents are homosexuals and the child originally doesn't have GD? But is it possible that because of the sexual orientation of the parents, the child may in turn suffer GD? We have done a lot of research on this. For same-sex parents and child adoption, the adopted child is not likely to exhibit more gender disorder issues than other children. There are research conducted overseas repeatedly showing the same findings. I asked Dr. Hong, so perhaps Dr. Ng, I let Dr. Hong answer first, and then I have another question for Dr. Ng. An expert called Judith Stacy had and 21 analyses, and the result was that for the children of homosexual parents, I mean, comparing to heterosexual couples, children of same-sex parents tend to engage themselves in sex at an early stage of life, and also to they may be more easily or more readily recognize themselves as homosexuals. So what about risks, Dr. Ng? That is for the risk of the child of a same-sex parent suffering from GD. Is the risk higher? I told you from various research studies the result is negative. Although such research studies are being attacked, and of course there are always variants in research findings. The findings will not be unanimous, so that depends on whether you believe in the majority result or the minority result. So you agree that there is a risk? No, I said no. 99% of the research findings show that the result is negative, and there is 1% negative, 1% positive. And if you want to talk about research studies, it may take days for us to discuss them. Can I supplement, Chairman? Frankly, on this issue, I think political correctness has overridden medical research findings. So sometimes you may receive heavy criticisms if you take a particular stance. So according to Dr. Hong, we should be objective, and we should also view this matter from the ethical or moral standards of the particular place, and I agree with him. So we've heard views from experts, and we will continue to have a discussion on that. Ms. Emily Lau. Thank you, Chairman, and thank you, experts, for coming to broaden our horizons, and I really hope that we can have an open discussion with an open mind. And Dr. Ng also talked about the genderization. I'm sorry I was late, Chairman. I have a question. Well, it seems that we keep referring to it as an illness. So can you first tell me whether this is a psychiatric illness or not? And in public hospitals, and I've also received a case in my ward office that there are patients waiting to have the surgery, and the waiting time is very long. It seems that there are not sufficient resources, not too much resources for this kind of surgery. Dr. Mack. As for services in the public sector, there is an ongoing discussion, and earlier the HA announced that there will be an integrated clinic to handle transsexuals cases. As for waiting time, this may not be directly related to the surgery. For different cases, the time for assessment, the period for assessment may be different, and there may be personal circumstances that have to be clarified first. And the HA will be setting up a central clinic to handle these cases. I believe your concerns can be addressed. So what about the first point? Is it an illness? Is it a disability? Now, the medical profession, at a very early stage already, identified that the homosexuality is not an illness. What about disability? Now, for those with gender dysphoria, GD, as mentioned just now, when we talk about disability, there are several criteria. Apart from their psychological gender recognition not aligning with their sexual traits, causing anxiety, we also need to look at how this anxiety affects his daily living on, say, his relationship with friends, with family members, such to the extent that the anxiety affects his day-to-day living, before we call this a disability. So this is not a psychiatric illness. Is it unanimous in your sector? Because we have heard different views. Now for homosexuality, as far as the medical sector is concerned, it is not a psychiatric illness. So you accept that there are some born with this orientation, so this is not a disease or an illness. It's of course you may have your own views, but you shouldn't call it disease or an illness, and you should not ask medical professionals to answer this question. So if it's not an illness, then why is it under the Department of Psychiatry? I'd like to clarify this as well. Dr. Hong? We agree that homosexuality. Chairman, let him continue, please. Mr. Chen? Yes, I want to clarify this because Ms. Emily Lau is talking about sexual orientation, and the doctors are talking about GD, and GD is in itself a psychiatric illness because she was late. I'd like to clarify on the point of homosexuality. We agree that homosexuality per se in itself is not a mental illness or a medical condition. However, it doesn't mean that this person is living happily. A person may seek counseling, or he may seek help. He may even want to change his ways, to change his sexual orientation from being a homosexual to otherwise. So I think the logic is not right. Homosexuality, like gender recognition, are affected by inherent and social factors. So if you say that homosexuals are born that way, and it's misleading. Chairman, you put a very good question. If it's not in psychiatric illness, why are we inviting psychiatrists here? Ms. Sithole.
Let me first with my question. I'd like to first of all thank the experts for coming. I'd like to explain why we think that persons who want to seek have their gender reassigned should be required to go through the SRS. Doctors, of course, are there to help the patients. The operation is not a torture. If it were, it is the government which would impose such a torture, requiring the patients to go through the full surgery before they will allow their gender to be reassigned. So the criticism is not directed against the experts, but rather the officials who've come up with this policy. My question for the experts is that when we amend the ordinance, the basic question we have to ask is whether or not the patient has to go through the full operation, whatever the psychological assessment, before the person can obtain the new sexual identity. Is that the appropriate approach? This, I think, is the most fundamental question we need to answer in the amendment exercise. The government's requirement is that the person will need to, the transsexual will need to go through the full SRS before he will be allowed to have his gender reassigned and be allowed to marry. And whatever the profession, you may have your professional expertise. You may not be too familiar with public administration. The person who is most familiar with that, it would probably be Dr. Ng. I think an individual's behavior and the collective behavior of society are two separate things. When we comment on matters relating to public administration as a professional, how can you avoid prevent the public from being confused that your comment about public administration has nothing to do with your identity as an expert, so that we can avoid the misunderstanding. People wouldn't have the misunderstanding that even the doctor is saying that you go to a transsexual who's a man go into a female toilet is not breaking the law. I think we should try to avoid such misunderstanding. Dr. Ng. I have always tried my best to impose my values on the whole world, but I don't think anybody can do that. If what I've said is misunderstood by some people, I can only apologize. I think Ms. Ho is most correct in saying that the so-called torture is something that is done by the society and not by doctors. So looking at it this way, I think requiring the transaction to go through the whole SRS is really unnecessary. It's really an unnecessary obstacle. If you remove the entire sexual organ, some people say in the case of a woman, you may need to remove the breast. For men, you have to remove the beard. You can go on and on. So it's all very arbitrary. What do you mean by removing all the sexual traits? The full SRS would obviously be a torture. And I also like to supplement on what Dr. Hong said earlier. That something that is not a disease, it doesn't mean that it is, it is inborn. Many people have, gender or sex issues, whether or not it's prenatal or postnatal. My personal view is that whether it has nothing to do with whether or not you accept it. Let's say if I like to study medicine, it has nothing to do whether or not it's done to nature or nature. It has nothing to do with it. The thing is, why do you not accept my choice? Where have I offended you? Never mind whether it is prenatal or postnatal. Even if it is postnatal, I still have the right to choose this lifestyle, so long as my lifestyle doesn't offend you. So for transsexuals, I think we have to think in the same way. After transsexuals has gone through the sexual reassignment, so long as it doesn't offend you, it doesn't cause any panic on your part, can we not accept that? Paul Chair. I think if we look at the Eurovision contest and saw the performance of this person, this man who disguised himself as a woman, although he has all the traits of a man. He's very popular, but on the other hand, his taking part in the contest is very controversial. But anyway, putting that aside, I would like to ask the experts a few questions. Dr. Ng, you seem to be more an expert on psychology than physiology. Now, for people suffering who have GD, psychologically speaking, to what extent, how would they be satisfied? To what extent would they be satisfied? Would they go to the extreme and want to everything, including the right to marry, or even exposing his sex organs in the toilet of the opposite sex? He may not need to do something obscene. He may, behave in a coy manner, although he's legally recognized as having been sexually reassigned. So he would have the right to do certain things. So does it mean that after they have been sexually reassigned, can they still insist on have the right? Should they insist on having the rights of his original gender, or what? So I mean, I would like to invite any of the experts to respond. Dr. Ho. Like I said earlier, the needs of different patients vary. We would look at the symptoms, the gravity of the problem, and then we'll conduct an assessment. We will be in dialogue with the patient. We have an open mind. When the patient comes to us, we do not have any specific target as to whether or not he should undergo hormone treatment or go through SRS. We do not have any preconceived treatment protocol. I'm not talking about yourselves, but rather the psychological state of these people. to what stage will they demand that I mean, do they have such demand, or would they be satisfied that they, so long as they can live free, choose their own lifestyle? For smokers who want to smoke everywhere arbitrarily, then of course the society will not accept that. But do these people insist that they should be entitled to all the rights like everybody else before they'll be satisfied? Well, that will really depend on the person. Different patients' needs are different. Some would. So you have some serious cases like where they would want to go through the whole SRS and eliminate everything that is inconsistent with his own sexual identity. So there's no general conclusion. So there's no. It all depends on the person, really. There's no standard treatment protocol. Dr. Ng, would you like to supplement? I don't have anything further to add, but according to my understanding, many patients would only live in their reassigned sexual identity so long as they can live freely if they can enjoy the protection of the law, and that they'll be entitled to the rights to marry, to adopt children, and so on in the capacity as of the reassigned sexual identity. Helena Wong. Once again, I'd like to thank the experts. My question is that, according to the law, persons who have received the full SRS operation, the bill as it stands explains what is meant by the full SRS operation. There is a legal definition for that. But the experts said just now that people with GD, it's all, I think when they come to you for treatment, they would like, let's say they would like to have the sex reassigned. If in the case of a female wanting to become a man, the breast may need to be removed, but they may not want to construct a penis or a fake penis. So my question is that for the orthopedics, I think removing a sex organ is a lot easier than reconstructing the sex organ. But the bill as it stands said that for a female wanting to change to a man, the uterus and the ovaries would need to be removed, and that a penis should be constructed. But that may not be entirely safe. So in the cases that you've handled, I think you said the situation varies from patient to patient. But if the bill would define clearly what is meant by the full SRS, including what need to be removed, what need to be constructed, and that means in the future, after the transsexual has gone through the SRS, and the psychiatrist like yourself may need to sign a certificate. But what happens if the patient has only gone through part of the operation? Then you cannot say that he has gone through the whole SRS. My question is, of the patients that you have come across, even if the bill became the law, these patients may not qualify to become a transsexual, and as a result will be entitled to marry. If we say N, use the word 1, 2, and 3, as I said, Dr. Ng said that this is a torture because not very few people can go through the whole operation. So if the bill becomes law, it may not be able to even help one person. That will be wasting our time. So if we spell out clearly in the law, the way it is worded now in relation to SRS, do you think it can really help? I believe the experts are all psychologists and psychiatrists. Last time we had the surgeons who met with us. Last time, Mr. Yuen already told members that we're talking about a full operation, and we've already helped almost 100 patients, and in future we'll continue to help these patients. So it's not doesn't mean that once we've set the threshold, we will not be able to help even a single patient. The question is, for those patients who don't want to undergo the entire SRS, or those who don't want to have an operation at all, do we owe them anything? Dr. Ng already said that this is a question of balancing the rights of different people. Like Dr. Ng, I would always coach my patients not to engage in behavior which offend other people. But then it's not a question whether of you're teaching the patients what to do, but rather whether he has the right. If you give him such a right, then he has the right to go to the changing room. He has the right to remove his clothing there. The question is whether or not other people, women or young ladies, will be shocked or and so on. As legislators, you have to balance the rights of both parties. You should not be inclined towards one side, protecting the rights of one group at the expense of another. That's not the crux of my question. My question was that we've heard from some transsexuals who came to talk to us and indicated that they want to have the sex reassigned. But then, due to their own physiological state, it's not suitable for them to go through the SRS. Therefore, they are left in limbo. They cannot be called transsexual. They might have gone through part of the operation, but they cannot proceed any further. So, if we insist that the patient must go through the full SRS, then they'll be stuck. So, have you heard of many such cases? Very, very clear. I think we need an answer from the experts. Dr. Fernando Cheung. Thank you. I'd like to thank the doctors as well. We're now talking about that is people with GD under the framework of heterosexual marriage. I think to what extent do we need to be would they before they will be given the right to marry, to form their family, and so on and so forth? To what extent of the surgery do they need to go through? The administration is now saying that they have to receive the full SRS operation before they would qualify. Now, if the full operation is not completed, then they will not qualify.
So one of the controversies is that if the patient is asked to have a full SRS, and this is torture, and the doctors said that this is not torture, this is of his own volition, and after the surgery he becomes much happier. So my question is, for friends, for people with GD who would like to get married, but who would not like to have the full SRS, under the proposed legal framework, there is a requirement for full SRS, then this will exert pressure on this individual, because only after having full SRS will this person be entitled to get married. Otherwise, this person will not be able to start a family, get married and start a family. And this will become a problem, because the person will be forced to, or he will be forcing himself to undergo the full SRS in order to be entitled to get married. And whether this amounts to inhumane or degrading treatment, whether this is contrary to the spirit of the International Convention. If the person originally doesn't want to have a full SRS, but because of his desire to form a family, he has no alternative but to have the full SRS, and does it amount to inhumane treatment? I think it's better to put this question to the administration rather than the four psychiatrists. Perhaps as psychiatrists, from your perspective, would you consider the person being subject to immense pressure or distress because of that, Dr. Hong? Of course, this will be a distress to the individual, but the point is whether he should be given this right simply because of that. I came across some counseling cases for married couples, and the husband has an affair, and it's distress for the husband because he would like to marry that other woman as well. They would like he would like to have both, but under the existing legal framework, he's not allowed to do so. So we do not just look at the individual's opinion, but rather the whole society as well. Who else would like to supplement, Dr. Ng? But Dr. Hong, he cited a very good example of married couple having an extramarital affairs. So that shows the flaw of the marriage institution. But that's for another topic of discussion. Indeed, there is pressure on some patients if they are forced to have full SRS by circumstances. Now, Dr. Hong, I mean, if we need to find a compromise, then it's up to the medical doctor carrying out the assessment to decide whether by doing or not doing so, it would pose great harm to his mental state, etc. I think this is also another possibility. Next, Mr. Christopher Chung, followed by Mr. Ray Chan. A question for the experts. I came in late. I didn't catch it clearly. Now, it's said that after surgery, this person may become a disabled person. Is it reasonable? He, on his own initiative, asked for the surgery, and after the reassignment surgery, now he may have dysfunctions, but that also happens to normal people, so to speak. That he may be impotent, he may also have other sexual dysfunctions. So this is unfair. If after surgery, because he cannot have 100% normal functioning organs, then he is regarded as a disabled person. I think this will be confusing. Now, on the other issue, I don't think this is just about washrooms, but also changing rooms as well. In a changing room, if somebody with the sex organ of an opposite sex just appears and stands there, and other people may not be prepared to see such a scene. They may not be psychologically prepared, and will that be a problem? If you ask this person to go to the place where his originally gender belongs, and there could be other problems. Dr. Hong. I'm sorry if I didn't make myself clear. For patients with GD, even before a diagnosis is sought, this person is already regarded as a disabled person. He may be even eligible for disability allowance. It's not a matter of having the surgery or not. Just like a person with hypertension, the treatment may help his condition, but he may still have hypertension. So like I said, it's not the case that this person becomes a disabled person after surgery. Surgery is just a form of treatment. So in that case, even without the sex change, I can be a disabled person. If psychologically, because of this gender recognition disorder, or a sex orientation, then I could be a disabled person. Well, but you talked about sex orientation. Now, my question is, what if I experience some dysfunctions because of my age, my senior age? Then what about that? Now, when we talk about the disease or an illness, we looked at the functional impairment. Only if that condition affects his appetite, his working capability, his day-to-day living, etc., would we classify it as an illness. We call people, some homosexuals have illnesses not because of homosexuality, but because of their lives being affected. They may be distressed, but they are not functionally impaired. Homosexuality per se is not an illness. That's why I say that. I hope everyone would understand from this psychiatric perspective. Mr. Ray Chan. Thank you, Chairman, for accepting my suggestion and inviting psychiatrists here today to explain to us. Now, one point left untouched, and that is sex change is not an easy thing. It's you have to go through stringent process. You need to see the doctor and receive medication, and it's not just somebody's wish whether you want to change or have sexual reassignment easily or not. And I have some questions. Dr. Hong talked about the 3 steps of treatment. The first is to try to change psychologically the person's gender recognition. Now, if this step fails, the second step is to help the patient live with the differences. So that is, as long as he survives without committing suicide, then that's all right. Then the third step is to provide medication or surgery. So, Dr. Ng, my question for you is Dr. Hong's theory a minority, in the minority, or is it a majority that the 3-step process will be adopted by the majority of doctors? And the other point is that originally across the world the approach was quite stringent. Perhaps close to full surgery is required, but nowadays the concept is more relaxed. So is it because of medical advancement? Is it agreeable to the medical sector? Dr. Ng, the 3 steps, can I answer now? The 3-step process. Now, to my knowledge and in my experience, and for my experience in participating in gender recognition groups across the world, the first step is assessment. That is, assessment must be conducted to see whether it is a deep-rooted psychological condition and an irreversible one, that sex reassignment is necessary. So it's just for assessment purpose. It's not for changing the mindset of the subject, because from research findings, it's proven to be unsuccessful if you want to change the psychological condition of such patients. And sometimes, some patients may want to have sex reassignment, but this patient may already have been married with a family, and he may not want to have the SRS, and he may then have to consider living with the difference. But in the end, usually it's a painful experience. Usually he'll just have to separate from his wife and his family. Now, as for the third step, it's largely a medical decision, in my view. I think in the past, the medical sector didn't understand that a lot of transsexuals didn't, in fact, want to have sex reassignment at all. In the past, we thought that most transsexuals would like to have their sex organs removed, and that's the cases that I came across. But eventually we found that some transsexuals didn't want that, and if we could provide an alternative way of life for them and help them, then they'd be happy to keep their sex organs. And this may not be socially acceptable at the moment, and that's why we ask for more tolerance from society for these patients. Mr. Kwok Wai Keung. First of all, I need to say that even when I was in school, I have been listening to Dr. Ng's speeches. I thought he was really ahead of times, and nowadays he has again been ahead of others. And today I want to emphasize on the marriage ordinance. Now, according to the marriage ordinance, the marriage institution is one of man and the marriage between a man and a woman, and it's about man changing into woman, and psychological state cannot be ascertained by the law. So medically, how can a doctor assess that the man should change his sex? I think under the existing Chinese customs and the legal framework, is difficult to do that. What we're concerned is what are the indicators or criteria for allowing such sex reassignment.
I think any of the doctors can answer my question. Dr. Holden, I think the indicator you mentioned, I think one of the crucial steps would be the real life experience. I think in assessing the patient as to whether or not he would insist that he would spend the rest of his life in a different gender capacity. In the course of real life experience, he may encounter difficulties, and they may have to reconsider whether or not he would still insist on having a sexual reassignment, and whether or not he still stand by his wish. So I think even for hormonal treatment, the effect would be irreversible. For example, after a man has taken the hormonal treatment, his pitch may change and so on, and that cannot be reversed. So the patient will need to go through an appropriate amount of real-life experience before we will discuss the question of operation. In the course of evaluation, we will talk to the patient about the different treatment options. But one of the critical stage is, I think in real life we'll be able to obtain a lot of information. and we can arrange for the patient to understand more about himself and before deciding how he want to live, his future life. Dr. Hong, if I may, supplement on what the professor said, by lenient, other than panic in the bathroom, Dr. Ng also mentioned the example of Argentina. Last year, a 6-year-old boy had already undergone SRS to become a girl. In Colorado, again, a 6-year-old child was suffering from GD, and his mother applied for him to be reassigned, to be sexually reassigned to become a girl. They don't know about the follow-up studies of children with GD. Some studies were undertaken in 1985. There have been some recent studies. 80 to 90% of the children with GD, the gender inconsistency can automatically disappear. According to my personal experience, I've helped a 4-year-old child change his GD. Should we, focus on politics? I mean, we're talking about, the right to choose one's own sexual identity. Adults have that right. Should children also have that right? As legislators, you have to consider the development. Today, we're talking about whether we would require the full SRS or partial SRS. The next stage, we'll have to argue whether there should be partial SRS and no operation, and then following that, whether the requirement should be, whether there should be assessment by doctors, and then following that, the next question is why is it that adults can have SRS and not children? And eventually, you will take the route of Argentina, where you don't need the doctor certification, and even at the age of 6, a person can be allowed to change his sexual identity. We have 8 members who would like to go for the second round, but apparently we won't have time for that. We must wrap up by 10:30. Originally, I thought that I could give 1 minute to each member, but I don't think we can accommodate all 8 members, so I'm afraid I will not be able to arrange for a second round of questions. Point of order, if so many members would like to raise questions on this topic, shouldn't we convene another meeting? It's not a question of rules of procedure. Whether or not we need to arrange for more doctors to, share their expert views with us. It would be a decision for members. But personally, I think, well, even the doctors today already have expressed many of their views. I think the judgment eventually would still be ours. Furthermore, there's a question of whether or not the doctors can also afford the time to come again. But anyway, I have to discuss with members as to how we should deal with the rest of the agenda. For the top 4 doctors, I would like to thank them for taking the time and sharing with us their valuable expert opinion on the question of transsexuals and sexual reassignment. Chairman, many members have other questions to ask yet, but you say that we don't have time for that. Of course, we are grateful to the doctors and the experts for attending our meeting today. I would like to officially suggest that the chairman will arrange for another meeting so that we can ask follow-up questions and the experts can ask our questions. I asked several questions, and Dr. Ng wanted to answer my question, but you didn't see that, and you give him the time to answer the question. No, that was because the time was already up. We specified that each member should be given 4 minutes. I think if we cannot resolve all the issues, we will not be able to proceed with the legislative exercise. Chairman, can we arrange for another meeting for the members to answer some of the questions which have yet to be answered? I think we can deal with that later on, but right now I'd like to thank all the doctors. As to how we deal with member suggestion, I think we can deal with that later. But once again, let me first of all thank the doctors again. Many members have indicated that we can invite the experts to have another meeting with us. Now, while the doctors are leaving the chamber, could we ask whether they will be willing to come? Should we extend an invitation to them again? Because we're now discussing the agenda for the next meeting. Of course, we're grateful to the doctors, but if we were to invite you to come again, because many questions have not yet been fully discussed, would you be happy to come again? Yes. Thank you very much. Well, we need to reschedule my appointment, so please let me know well in advance. Now, the question is whether before July the 16th, we would be able to complete the scrutiny of this bill. 14 members said that we should, aim for that target. And given the progress today, then we may need to convene more meetings, and we will need to meet more frequently before we can meet the deadline of the 9th of July. It's already the 5th of June, so we don't have very much time. So that's the first point to bear in mind. Members indicated that we would like to have more discussion with the doctors and experts. Well, the timing is again a crucial issue. So may I ask first of all whether members would like to attend another meeting within a very short notice? Mr. Poche. Chairman, I'm afraid this is not an issue that can be resolved by arranging 1 or 2 meetings. Otherwise, the administration would not have, set up a bills committee for that. So I don't think we may need to ask the doctors to come repeatedly. If we really are keen, we can certainly, conduct some research ourselves. Tommy Cheung, I agree with Paul. I'm also reading some literature on this subject. It's a very complicated subject. Other than our personal belief and our family values are at stake. So I may have a different view from the chairman. I don't think we should scrutinize this bill so hastily because it's very controversial. I hope that we can deal with it. I hope it could be simple. I would rarely repeat myself. Why don't we, allow me to finish? Otherwise, I'll leave. So I don't think we should act in haste. And as a result, we do not need to do a lot of things within a short period of time. The court has passed down a judgment, and the government has to act accordingly. The CFA has indicated that we have a year. So, and many of us have asked whether or not we should finish this exercise within a year. Well, I agree that we shouldn't act in haste. Fernando Joe. Well, it's very rare that I agree with the chairman and Mr. Tommy Joe. That is, we shouldn't act in haste, because this is really a very controversial subject. So we do not need to deliberately expedite the pace of our work. Well, we've conducted. Let's circulate a questionnaire and circulate to members. The question I asked is whether or not members are willing to have more frequent meetings within a short period of time. I mentioned the deadline of July the 16. I said if we are to make the deadline, we have to call for more meetings. So I've heard members' views, and I don't think we can continue any further today. So at our next meeting, we've already scheduled that for the 10th of June. We can have another meeting. Many of the members would like to invite the doctors to come again. Do members? Well, should we invite just psychiatrists or psychologists, or do members only want to listen to the views of those doctors who are present today, or even general practitioners? So, all right, we can invite the doctors to come again on the 10th of June, but whether or not they will be available, we have yet to know. So bear in mind that we have a very tight schedule. At what time will we meet on the 10th? 4:30. June 10th at 4:30 in the afternoon. This may clash with the FC meeting. It's a Tuesday. It clashes with the one involving pharmacists. Okay, then. Well, I have to attend another panel meeting which finishes at 5. Well, that can't be helped. I'm afraid there are bound to be clashes with other meetings. Paul Chair, I'd like to suggest that we invite Professor Robert Amberton from the Hong Kong University. He has written a lot of books on the subject, and I think the CFA judgment also made reference to his work many times. Okay, could you give us the information? With that, I think we may now adjourn our meeting. Thank you.